Hello everyone, we are Group B4. Our presentation topic for today is spontaneous vaginal childbirth and planned operative delivery. This is the content page for today's presentation. We will first introduce the background and the indication and the procedure of both delivery methods. Then we will analyze the benefit and risk for both methods. And at the end, we will provide a Q&A section. For background, I will introduce spontaneous vaginal delivery and planned operative delivery. Spontaneous vaginal delivery is the method of childbirth most health experts recommend for pregnant women whose baby have reached full term. Compared to other methods of childbirth, such as a cesarean delivery and induced labor, this is the simplest kind of delivery process. A spontaneous vaginal delivery is a vaginal delivery that happens on its own without requiring doctor to use tools to help pulling the baby out. And cesarean section is the planned operative delivery. This is the surgical delivery of a baby through incision made in the mother's abdomen and uterus. This incision made in the skin may be up and down vertical, which this incision extends from the belly button to the pubic hairline, or across from side to side horizontal, which this incision extends across the pubic hairline. And this method is often because his heals well and there is less bleeding. For indication for spontaneous vaginal delivery, it is suitable for pregnant women who will give birth between 37 and 42 weeks of pregnancy. Moreover, pregnant women with low identified risk factor for complication, either for themselves or their baby, as the onset of labor are recommended to have spontaneous vaginal delivery. For example, there is no prolonged labor, no untreated HIV infection, no herpes virus with active lesion, no previous cesarean deliveries, no previous sterile surgeries. As a result, pregnant women with low-risk pregnancy and their baby in head-down position are recommended to have spontaneous vaginal delivery. For indication for cesarean section, ICD-10 codes for indication of cesarean section are grouped into 10 subclasses. The first one is hypertensive disorder, such as gestational hypertension, preeclamptic toxemia, and eclampsia. The second class is malpresentation, like bitch presentation, and the third class is the disorder of amniotic fluid, like oligohydramnia and polyhydramnia. The fourth classes is antepartum hemorrhage, including placental. The fifth class is post-date pregnancy, and the sixth class is prolonged and obstructed labor, such as cervical pelvic disproportion and failed induction of labor. The seventh class is fatal distress, and this is classified as non-specific fatal distress and fatal distress. Meconium liquor belongs to fatal distress, and the eighth class is previous cesarean delivery. The ninth class is maternal disorder related to pregnancy, including maternal distress, Rh-negative models, and retention of urine. The 10th class is general disease complicating pregnancy, such as thalassemia, anemia, and asthma. Moreover, maternal preference are also the indication for cesarean section. I will introduce the procedure of spontaneous vaginal delivery. The labor onset is caused by hormonal change. The progesterone relaxes the smooth muscle, and the estrogen stimulates the uterine muscle contraction. As a result, the connective tissue loosens and permits the opening of the cervix. For the signs of labor, the woman may feel lightening and ripening of the cervix. That means the cervix needs to open about 10 cm for the baby to pass through, and the woman will feel strong and irregular vertex contraction, and that is forced labor pain. And there are some signs of true labor. First is the uterine contraction. The woman will feel strong and regular uterine contraction. There is a part of mucus in the cervix. This part will come out before the labor starts. The mucus will pass out through the vagina. This is a small amount of sticky jelly-like pink mucus. Thirdly is the rupture of the membrane. This is due to the cervix dilation, and the amniotic fluid will drain out through the vagina. There are total 4 stages of labor. First stage is the onset of regular uterine contraction to full dilation of the cervix. It can last up to 12 hours or sometimes longer for nulliparia in this stage. For multiparia, it usually lasts up for 4 to 8 hours, and it is common for spontaneous rupture of the membrane in this stage. For the second stage, it is referred to full cervical dilation to the birth of fetus. This stage can last up to 1 hour for nulliparia, and for multiparia, it will use shorter times for this stage. The uterine contraction become more powerful and explosive in this stage. The woman can hold the breath to create contraction of abdominal muscle to facilitate the progression of this stage. For the third stage of labor, is referred to the birth of fetus to until the delivery of placenta. After the placenta separates, the woman can bear down in assisting the pass out of the placenta. The competence of the placenta and the membrane have to be checked to avoid the remaining parts left inside the uterus. For the last stage of labor, starts from 1 to 4 hours after the delivery of placenta. This stage is at the highest risk for hemorrhage at the first 4 hours after the postpartum period. The uterus remains contracted and fundus remain midway between the symphysis pubis and umbilicus. Now I'm going to talk about the procedure for cesarean section. During the cesarean section, most mothers are awake in the operation. They are able to see and hear. The operation is done with regional anesthesia, such as spinal anesthesia, which the mothers will have no feelings from waist down during the operation. The operation usually takes about 40 to 50 minutes. For the pre-operation, mothers should not have oral intake 8 hours before. They should shower with antiseptic soap at night before and the morning before. They should not shave public hair by themselves as it may increase the risk of infection. At the hospital, nurses should help mothers to insert the urinary catheter to draw urine and keep the bladder empty during the operation. An intravenous line should also provide to the mothers for providing fluid and medication and prevent fluid and electrolyte imbalance. During the operation, first step is to administer the anesthesia. After the effects of anesthesia, a horizontal incision will be made in the skin and the abdominal wall and uterus. Side-to-side cut will be used as to rupture the amniotic sac surrounding the baby. After that, the baby can be removed from the uterus and cut the umbilical cord of the baby. Then the placenta should be removed. Lastly, close the incision in the skin and uterus with stitches and examine the baby, then given back to the mother for skin-to-skin contact. For the post-operation, nurses should monitor the vital signs every 15 minutes for 1 hour, then every 4 hours. Monitor intakes and outputs every 4 hours, which the mother should not have oral intake for 8 hours after the operation. They can have sips of water after 8 hours. Clear liquids can be provided if they can tolerate it. They can resume regular diets after a bowel movement. Bed rest should be promoted for mothers. They should keep supine for 8 hours after spinal anesthetic because of the effects of the anesthesia. Their lower limbs might not move shortly. Promote coughing technique to cover the incision sites when coughing to prevent bleeding. Lastly is the pain control. Nurses should assess mother's pain level frequently to provide appropriate nursing interventions. They can also administer analgesics for mothers as orders.
First, the benefits of spontaneous vaginal childbirth in point of view of mother. According to research conducted in USA, women who give birth vaginally may spend less time in hospital and recover faster compared with the operated delivery. Women who undergo vaginal birth avoid having major surgery and its associated risks, such as severe bleeding, scarring, infection, reaction to anesthesia, and more long-lasting pain. Therefore, she is so much more able to care for herself and the baby and may begin breastfeeding sooner after delivery. Also, the cost for vaginal childbirth is much more lower than operated delivery. According to research mentioned, there is also benefits for babies. During vaginal delivery, muscle involved in process are more likely to squeeze out fluids found in newborn's lung, which is beneficial because it makes baby less likely to suffer breathing problem at birth. Baby born vaginally also receive an early dose of good bacteria as they travel through their mother's birth canal, which may boost their immune system and protect the intestinal tract. Besides the benefits, there are also some risks for spontaneous vaginal childbirth. During delivery, skin and tissues around the vagina can stretch and tear while the fetus move through the birth canal. If stretching and tearing is severe, a woman may need stitches or this could cause weaknesses or injury to pelvic muscles that control her urine and bowel function. Some study has found that women who have delivered vaginally are more likely to have problems with bowel or urinary incontinence than women who have had operated delivery. They may also more prone to leak urine when they cough, sneeze, or laugh. After vaginal delivery, a woman may also experience pain in the area between her vagina and anus. Next, we'll move forward to discuss the benefits and risks of the planned operative delivery. First, the benefit. It is a safer delivery method for delivered twins or other multiples. And safer choice for patients have medical conditions such as diabetes or high blood pressure. Also, it helps to deliver a very large baby in a mother with a small pelvis, or lower the risk if the baby is not a head down position or an effort to turn the babies into this position before birth have been unsuccessful. As the operation can be scheduled in advance, it makes more convenient and predictable. Finally, for the risk for planned operative delivery, mother may have longer recovery time and hospitalization period, as more pain and discomfort in her abdomen, skin, and nerve surrounding, and result in delayed breastfeeding after her delivery. Also, it may increase women's risk for more physical complaints following delivery, such as pain or infection at the site of incision. As the planned operative delivery is equal to undergoing a surgery, so it will increase the risk of blood loss and greater risk of infection. The bowel or bladder can be injured during the operation or a blood clot may form. Greater risk for further pregnancy complications such as placental abnormalities and uterine rupture, which is when the uterus tear along the scar line from a previous.
If the mother received CS before, there are some implications for further pregnancy and birth. For the positive implications, the mother may have lower risk of medical abortion, prolonged pregnancy, and abnormal force of labor. It can also prevent the preterm labor of the infants. In addition to some positive implications, there are some negative implications too. It will increase the risk of pregnancy-induced maternal disorders, including gestational edema and proteinuria without hypertension, gestational hypertension with or without proteinuria, polyhydramnios, and placenta previa. The risk of pregnancy-associated disorder will increase, like having hemorrhage in early pregnancy too. During a labor process, there are some complications like having longer labor time.
In a study found that there were more pregnancy women who received vaginal birth after CS, VBAC, associated with longer labor time. VBAC women had higher rate of episiotomy than that of spontaneous vaginal birth last time. Therefore, the successful VBAC rate was lower with 50 to 85%. There were 15% receiving emergency lower segment CS and failing of vaginal birth. That shows that VBAC may affect the mode of birth. If the pregnant wants to give birth with spontaneous vaginal birth, she needs to consider the risk mentioned before. The most severe complication is uterine rupture. This may also affect the infant after birth in second pregnancy, including increased risk of assisted ventilations, lower Apgar score, seizure, frontal distress, and asphyxia-related neonatal death. This problem may increase the neonatal mobility and mortality. This is the end of our presentation. Is there any question about our presentation?
What kind of childbirth do you recommend?
We recommend spontaneous vaginal birth, as it has more benefit than cesarean section delivery, and its benefit outweigh than the risks. As we have mentioned, spontaneous vaginal birth can speed up the recovery time and shorter hospitalization period. It can also benefit the baby by boosting his or her immune system, while planned operative birth cannot provide.
What is the care after spontaneous vaginal delivery?
For the postnatal mother, she should keep the wound clean and dry and perform vulval swabbing after each emulation and change the vulval pad frequently. If there is gaping or edema of the wound, she should perform seed bath with 1% potassium permanganate. This is the reference page. This is the end of our presentation. Thank you.